Welcome to the image analysis of the shoulder. We're going to start with the AP projection. Image analysis guidelines for the AP projection of the shoulder state that the scapular body demonstrates minimal transverse foreshortening and half of the superior scapular body should be visualized without thoracic superimposition. The clavicle should be demonstrated with minimal longitudinal foreshortening and with the medial clavicular end positioned next to the lateral edge of the vertebral column. The glenoid cavity should be partially demonstrated with the humeral head superimposing it in a non-dislocated shoulder. The scapular body is demonstrated without longitudinal foreshortening, and the mid-clavicle should superimpose the superior scapular angle. The humerus is also demonstrated without abduction, so it should be next to the body. In a neutral projection of the humerus, or of the shoulder, the greater tubercle should be partially seen in profile laterally, and the humeral head is partially seen in profile medially. In an externally rotated humerus, the greater tubercle is seen in profile laterally, and the humeral head is in profile medially. In an internally rotated humerus, the lesser tubercle should be demonstrated in profile medially, and the humeral head should be superimposed by the greater tubercle. All projections should be marked and marked appropriately with the correct word marker, such as externally rotated, neutral projection, or internally rotated. In addition, image analysis guidelines state that the superior scapular body should be at the center of the exposure field. The glenohumeral joint, clavicle, proximal third of the humerus, and superior scapula are all to be included within the exposure field. The next couple of projections are demonstrations of the AP neutral projection of the shoulder, the external projection, and the internal projection. I will include the image analysis guidelines for your review on your own time. Let's move on to some common positioning errors. The first one demonstrated here is upper mid-coronal plane tilt, anterior tilt. If there is some anterior mid-coronal plane tilt, the scapular body will be demonstrated with foreshortening, okay? And then that superior scapular angle will be demonstrated superior to that mid-clavicular mid-clavicle point, okay? And so that is an indicative of that mid-coronal plane tilt. In order to correct this tilting, we need to make sure the patient MCP is parallel with the IR. When there is posterior tilt, you will see that there's the scapular angle is demonstrated inferior to the mid-clavicle. As you can see here, here's your scapular angle, and there is again foreshortening of that scapular body. So in order to correct this tilting, we need to get that mid-coronal plane parallel with the IR. Moving on, let's talk about some more common positioning errors when it comes to rotation. When the torso is rotated toward the affected shoulder, that resulting projection will demonstrate the medial clavicular end rotated away from, and you can see the clavicular end, away from that vertebral column and from that lateral edge of that vertebral column. We'll also see increased thoracic and scapular body superimposition, increased clavicular foreshortening, and decreased glenoid cavity visualization. When the torso is rotated away from the affected shoulder, that resulting projection will demonstrate the medial clavicular end superimposing the vertebral column, as you can see here in this projection. There'll be decreased thoracic and scapular body superimposition. There'll be decreased clavicular clavicle foreshortening, but there'll be increased glenoid cavity visualization. So let's look at our first practice analysis. In this first shoulder projection, we first want to identify, do we have all the anatomic structures within this projection? And for the most part, we do. Now we need to question patient positioning. The first thing we want to indicate is there any rotation or is there any tilt? When looking for tilt, we should recall that we want to look at this superior angle of the scapula. It is demonstrated superior to that mid-clavicle. So that should indicate to you that there is some mid-coronal plane tilt, which is anterior. In order to correct this, we need to ensure that that mid-coronal plane is parallel with the IR. You also want to look to see if there is any rotation, and the key indicator for that is foreshortening or elongation of this clavicle, which there isn't any. We should also be looking at the location of the medial clavicular end and its relationship to the vertebral column. It is lying in the appropriate spot, right lateral to that vertebral column, so there is no rotation. In our next AP shoulder image analysis, again, we want to ask ourselves, do we have all our anatomic structures that we are trying to image? And because there's so much going on here, we have something here of the shoulder, but it obviously there is some positioning errors that we're going to have to clean up and repeat this image for. So again, we're going to look for our left clavicle. Is there any foreshortening? Is there any elongation? The first thing that I see is that the left clavicle is foreshortened. The right clavicle is actually demonstrated across the vertebral column, which should indicate to you that the patient was rotated towards the affected shoulder. We need to fix this rotation. So in order to fix this rotation, we need to rotate the patient away from the affected shoulder until that mid-coronal plane is parallel with the IR. In addition, because of this rotation, the greater tubercle of the humeral head is not in profile. It's in partial profile. Once we fix that rotation problem, just ensure that you have that patient's arm in an external rotation so that we are make sure that greater tubercle is in profile to obtain a accurate AP shoulder external projection, rotation projection. In our last practice analysis of the AP shoulder, this looks like it was taken with a internal rotation projection. First, we want to make sure we have all our anatomic structures within the field of view. Next, we want to look to see if is there any rotation or tilt. The first thing that I look for is that medial clavicular end of the affected shoulder. In this projection, the medial clavicular end is superimposing the vertebral column. This should indicate to you that we are turned, or the patient is turned away from the affected shoulder. So we're going to have to turn the patient back so that the patient is in the mid-coronal plane is parallel with the IR. We also see a little bit of tilt by looking at the superior angle of the scapula. You can see that the patient is tilting anteriorly. So we need to straighten up the patient so that that superior angle lies within the mid-clavicle region to get an adequately positioned projection of the AP shoulder. So let's move on to the Gracie method. Image analysis guidelines for the AP oblique projection of the shoulder. The Gracie method states that the glenoid cavity should be demonstrated in profile and the glenohumeral joint space should be open. 1/3 of the coracoid process should superimpose the humeral head. The glenoid cavity should be demonstrated without thoracic superimposition. The clavicle is longitudinally foreshortened and is horizontally situated. In a patient who is lying down or recumbent, the glenoid cavity is situated slightly superior and the clavicle is foreshortened, aligned vertically and superimposing the scapular neck. The superior margin of the coracoid process is aligned with the superior margin of the glenoid cavity. The glenohumeral joint is at the center of the exposure field. The glenoid cavity, humeral head, coracoid, anacromion processes, and lateral clavicle are all included within the exposure field. This concludes part 1. Please proceed to part 2 of the shoulder image analysis.